Murray from Edinburgh, Napier. She does a lot of research in applied health psychology as well as forensic psychology. And today she's going to talk to us about some of her forensic psychology work, specifically about violence risk assessment.
Thank you. I will admit I'm a wee bit of a pacer. I've already paced, but there's a mountain here that I'm likely to fall over, so if you see me starting to tumble, just ignore me, I'll get back up. But I'm going to try to stick on this side of your awkward trip hazard, which is awful. I'm also clumsy, so if I splash the water, just ignore me, I'll clean it up later. So today I'm going to be talking about my PhD research, actually, which now feels like so long ago. I'm still in the process of publishing it, so I completed my Viva with really minor changes in 2010, graduated in 2011. So it's obviously 2015 now, so it's getting a wee bit old hat. However, the latest paper from the PhD was published just last year, at the end of last year. There's one paper to go, and that'll be 8, and that'll be me done, and I can put it to bed and never look at it again, which would be lovely. So I'm going to talk a wee bit about what I did and what I want to do, where I want the work to progress to. And as Jen said, I'm a forensic psychologist, but not officially a chartered forensic psychologist. I work in forensic psychology, and since my PhD I've been working in the applied health field, not so much health psychology, but applied health research fields, following a couple of research fellowship positions. That's kind of broadened my horizons and my perspectives on this work, so I may meander a wee bit from the slides, hopefully not too much, and it's quite good to have that wider perspective. So the top objectives, you can tell I wrote this a long time ago and not recently because it's got nice objectives laid out. So I'm going to talk about the impact of decision-making biases and decision-making heuristics on judgments of violence risk assessment. And this is across judgments that have been made by lay people, so they're not experts in forensic psychology, clinical psychology. They've never done a violence risk assessment before. Semi-experts are people also called novices, people like assistant or trainee psychologists who are just first step into the domain of being a practitioner. And expert participants. So my expert participants were clinical psychologists or forensic psychologists who had been in post for at least 2 years. Some of the key stages of assessing the risk of violence is also what I'm going to be looking at. So in the PhD I wanted to look at not just one little niche area of violence risk assessment, but different types. There's various types, and I'll go into that in more detail right now. So initial unaided clinical judgments of violence risk assessment. Judgments made that have been created using a violence risk assessment tool. I used the HCR20, which is one of the gold standard violence risk assessment tools, broadband violence risk assessment tools, and also looking at the impact, if there is any impact, of decision-making biases on risk communication. So, are these biased judgments being translated into risk communication? Now, I have to apologise for the transition slide thing. My husband put on these beautiful transitions. I know some people find them really irritating, I personally do as well, so anyone in the audience that doesn't like the fade effect, I don't either. Me and Jen were trying to work out how to get rid of them before I spoke, couldn't work it out. So they're there, I'm afraid, for the whole talk. So anyone who's not aware of what attribution is, I'm assuming everyone's psychologists? Everyone heard of attribution at least, maybe? I'll give you a really brief thing. It's something that surely we all do at undergraduate level, but many of you probably haven't looked at it since then. So attribution theory basically suggests that individuals attribute either an internal or an external cause or motivation to a person's behaviour or to their own behaviour. In my case, in my research, I'm interested in their internal and external attributions of another person's behaviour. So an external attribution to a behaviour could be applied when the causality is thought to be something external to that individual, something situational, for example. So the man hit his mum because she was patronising him, she was being mean to him, maybe belittling him, and this was basically goading him into doing it. An internal attribution, on the other hand, would be applied when you apply some kind of an internal cause to that person's behaviour. So it's something to do with that person. So he hit his mother because he's got a terrible temper, or because he's a psychopath, or he's just a nutter, which is something papers tend to like to say. So there's this difference between the internal and external causality, and that's what I'm interested in terms of the attribution effects. So violence risk assessment is the target that I was interested in. There's been tons and tons of attribution research over the decades, like thousands of papers, but surprisingly very little in the field of forensic psychology, and surprisingly very little in terms of violence risk assessment. There was maybe, when I started my PhD, 2 or 3 papers that were empirical that I could find that were half decent. So it's still a baby field, despite attribution theory and violence risk assessment itself being such such old fields. So violence risk assessment has become it's really a key competency in the workaday life of a clinician. So clinical forensic psychologists do this quite commonly. It's basically part of their job. Assistant and trainee psychologists need to have this skill or develop this skill and role. And it's not just within the UK, it's not just within Western nations. A paper released just in December 2014 did a massive international study with thousands of respondents, and I think it was something like 92% of them take part in violence risk assessments every week, at least one a week. So it's something that people do a lot of when they work in a clinical forensic role. So violence risk assessment is basically the process for assessing and managing risks of an offender. So is this offender going to go out there according to your assessment and re-offend, or are they not? And what level is that? High risk of re-offending? Is it a low risk? Is it moderate? There has been 3 sort of golden ages of violence risk assessment. The first one was just clinical judgment alone, and this is where expert clinicians, so your clinical forensic psychologists, would say, oh, based on my intuition, based on my expertise and my knowledge of the field and my knowledge of this particular person, this particular offender, I believe that they are high risk of re-offending and X, Y, and Z should happen. Now, that's been very, very criticised in the literature. It's been found to be very prone to error. So to counteract this, in the 1950s and onwards, they proposed, the literature, the academics proposed that actually we get rid of the clinicians, we put them out the door, not get rid of them completely, but get rid of their judgment. And they developed actuarial tools. So these are predictive mathematical models based on risk factors that were existing in the literature. And these would predict the likelihood of somebody re-offending. Now, obviously clinicians didn't care for this because it's quite insulting to somebody who's trained for 8 to 10 years or more to become an expert clinician, or who knows their job very well. So they don't generally like actuarial tools. There's also an issue with prediction. So can we really predict what somebody's going to do? Can we predict how dangerous they are to the public? And proponents of actuarial methods would say yes, we absolutely can, we can forecast, that's absolutely fine. People who are more supportive of clinical judgment say, well, no, actually, there should be a negative correlation between a risk assessment and the actual outcome. So if the clinician's been doing their job and assessing and managing the risks, so the management's important, then actually the person shouldn't be re-offending, even if they've been rated as high risk in the past. So it's a bit of a debate that's still ongoing in the field, and I think it just depends on how you've been trained and what your own beliefs are, what your own clinical biases are, I suppose. So the next age of violence risk assessment, which is the one we're kind of in just now, uses structured professional judgment tools, and this is it's not a combination of actuarial tools and clinical judgment, but it's using evidence-based headings, evidence-based risk factors and protective factors from the literature, and the clinician basically uses these to help guide and formulate their risk assessment and guide and formulate the risk management plan and intervention plan as well. So it's not a scored measure, or although some people use it as a scored measure, and certainly in the research it looks like it is, and they are, but they're a wee bit more evidence-based, they're a bit less airy-fairy, and there's less wiggle room for clinicians who maybe aren't quite as good as some of the other clinicians. So it's a bit more objective and standardised. And I'm going to be looking at the clinical judgments, the unaided clinical judgment, and also the structured professional judgment. I didn't want to touch actuarial methods with a barge pole, to be honest with you. That was my entire reason for not including it in the thesis. I didn't want to. So very evidence-based. There's still, however, although we talk about clinical judgment a lot, and we talk about how poor clinicians are at judgment in the literature, I don't. Other people do. I support clinicians. There's actually still very little focus on the actual psychology behind the decisions and judgments in this context, which is surprising given that decision science has been around for 70-odd years, 60-odd years. So decision-making psychology is a very fruitful field. It's very busy, it's very prolific, but we're not using it. So that's what I wanted to do, is to pull these all together. So clinical judgment itself, so the unaided clinical judgment, is the most commonly used approach to violence risk assessment in practice. This is still true today. There was a paper published just in November, a few months ago, that actually found that people are still using unaided clinical judgment as their main decision-making process in violence risk assessments and management plans, despite the fact that there's this myriad of tools available to them. However, it's been highly criticised within the academic literature, as I've already mentioned. It's really common to find within papers that 2 out of every 3 predictions of violence made by clinicians are incorrect, and usually Monaghan's cited, Monaghan 1984 classic paper cited. Now, again, looking back at this, we've got to think, well actually, if there's been an intervention plan, if there's been a risk management plan in place, then yes, these initial predictions should be wrong. Other things happen in people's lives than just, oh, you predicted to be violent and you're going to go out and stab somebody or hit somebody. Of course more happens in between. And these very statistical record-based studies can't take all of that into account. So while it's still quite alarming, the figure is alarming, we have to think in the broader context. So what else is going on in the decision-making in the judgment phase rather than just numbers? So a classic paper by Litvak suggests that there's actually hardly any empirical support for the assertion that clinicians are crap at their jobs, basically, and that there's been this rush to negatively judge clinicians' capabilities. Certainly in the 70s, 80s, 90s, especially the 80s and 90s, the majority of papers were really, really harsh on clinical psychologists and forensic psychologists. Nowadays, they're not quite as harsh in the sort of 2000s and 2010s. So far, papers have been more supportive, trying to look at different approaches to risk assessment, approaches to clinical judgment, which is nice. There seems to be a change in tide, at least in the papers that I read. And hopefully that will help with things like participant recruitment. It is really, really hard to get clinicians to take part in your research because they are so suspicious of research, or at least in my experience they are, until they get to know who you are and what you've done. They generally don't want to take part in a study only to find out that actually they're going to be bashed again. I have been accused of going native with clinicians, which is a nice term, I think, and it's basically a derogatory term of saying that you're a bit too sympathetic there, Jennifer. But when you've got 2 decades worth of papers belittling your profession, I think actually it's a bit harsh when there's a lot of things that haven't been done, haven't been investigated and haven't been addressed. So why did the negative perception of clinical judgment arise in the first place? Well, it's all fine and well said we're too hard on clinicians. Certainly there's examples of really classic papers and classic rulings. So the Backstrom ruling, which was reported by Stedman and Kokoza, way back in the 60s, it's still cited so much in papers, it's really classic. Just under, I think it was 700-ish, I can't remember the exact numbers, and that looked wonderful in the film. I did know this morning, but I can't remember off the top of my head, but hundreds basically of offenders were released out from a high security institution out into the public. People thought this would be absolutely catastrophic. They thought crime rates would skyrocket because a lot of people were rated as high or moderate risk. And actually what they found was crime rate didn't really change. Petty crimes went up slightly, follow-ups, there was quite a lot of petty crime. There was no major violent crimes, or not no, but none that were sort of above the normal distribution curve. So based on this, people started saying, well actually, what are these clinicians doing? These people are all violent criminals who are supposedly a risk to the public, but when they're released, they've not done much. They've not, nothing really ridiculous has happened. There's not been a spike in the murder rates or serious assault rates, so what was going on? So this was one of the proponents of the critique of clinicians as not knowing their risk, their risk judgments, not being good at risk judgment, basically. I've already spoken about the actuarial versus the clinical assessments of violence risk, and this study by Stedman and Kokoza was one of the first things that really brought about that idea that actually let's put clinicians' judgment to the side and let's bring in mathematical modelling. In addition to that, there's been a number of expert versus lay people studies, one of which I'll talk about in a wee second. And the expert lay studies are really interesting. I love expertise research, I think it's so fascinating. And a lot of these studies find that actually expert and lay people's judgments look pretty much exactly the same. And this finding is seen, if you look at expert versus lay chess players, if you look at poker players and various other fields, you see this same expert lay similarity. So it's not, it's not just violence risk assessment that we see this, but then one of the arguments was, well, if they're no better than lay people at getting the right answer, then why do we pay them so much money? Why are they so good? They obviously aren't. But actually there's a lot of stuff that goes on in terms of expertise development that can explain that too, if we look at it from a decision science perspective. And I'll talk about that later. So in terms of the actual decision-making psychology in violence risk assessment, there's really little empirical research on this topic. There are a few recent literature reviews, a few of them are mine, a couple are by a chap called Randy Otto, who's excellent, really good writer, really good thinker, at least through his papers he is, I've never met him. And the lit reviews are nice because they pull together the decision science and see how it might apply to violence risk assessment and violence risk management, how it might be used to improve the process. However, even though there are these lit reviews from, say, I think the first one that I came across was 2004, and there will be older ones, hardly any empirical research is being done. There is more empirical research, but not a lot. So why is that? Well, there's various reasons why that might be. Maybe people just aren't interested. It's not kind of a sexy area, I suppose. It's a bit of a boring statistical area for some. But maybe people just aren't aware of it as much because there's not a lot out there. One of the studies that I came across that really fascinated me, and part of it really shaped my PhD, was by Quincy and Sir. And it's 1986, so I was only 1 year old babby when this came out. But even when I started my PhD, it was 2007, even then it spoke to me. There was no follow-up research to this study. There was nothing really prior to it that was similar to it. So it was like this wee sore thumb in the violence risk assessment literature that seemed to have some potential. So they conducted expert and novice research, actually it was expert and layperson research, that looked at the effects of internal and external causality, so attribution essentially, on judgments of violence risk assessment, and this was unaided judgments. What they found was that there was little difference between the experts and the lay people in terms of their ratings of dangerousness and offender responsibility for their crimes. So other people's assessments of how dangerous an offender is and how responsible they are for their crime based on attributional judgments, experts and lay people were pretty much the same. So that mimics what we've seen in the past and what we've seen in other fields. These findings were used to present further evidence that clinicians are actually, they don't really have any special expertise at all in their field in violence risk assessment. That's a bit bleak, isn't it? Perhaps maybe I'm just an eternal optimist. But looking further into the study, looking at the nitty-gritty details, there are some limitations, as there are with every study. But one of the key ones that struck me was the sampling issues. Now, it was a small sample. All of my studies are small sample. I'm sure many of you guys will have the same issues of recruitment of these niche groups. So let's ignore the teeny numbers and look into the numbers in a bit more detail. So they had 24 experts take part. Only 16 of the experts had clinical experience with offenders. Now, if you're asking people, if you're labeling people as experts in violence risk assessment, then surely all of them should have violence risk assessment practical experience. Now, I've done training in violence risk assessment, various tools. I've done my PhD on it, I've published in it. I would never pretend that I was an expert clinician or practitioner, of course not. So it seems odd that people like myself perhaps are being labelled as expert clinicians when they're just maybe not. If you don't have clinical experience, then you don't have it. Of the 16 participants, with offender experience, the authors of the paper didn't actually state the precise nature or length of time of this experience. I did email to inquire about it, but I never got a reply because I was a PhD student at the time, I suppose, and the study is very old. Now, the length of time of their experience could be important. If they've perhaps only had 6 months of clinical experience, how can that be equitable to someone with 15 years experience? And that's something that I wanted to pick up on and do pick up on in my research. So were these experts truly experts, or were they perhaps novices, or some of them novices? And that's quite important to define it properly and to clarify that. Now, it could be that they are genuine experts, but we don't know. The expert sample also contained 3 psychologists and 21 psychiatrists, and 21 psychologists. Only 14 of the psychologists actually had doctorates. That again suggests to me that, well, perhaps these are trainee psychologists, perhaps they're assistant psychologists that have taken part. Not that you need to have a doctorate to be an expert in something, you certainly don't. But again, it's interesting that these different levels of qualification are being bunched into the same bundle. So the findings could potentially be affected by lack of real expertise within the expert sample. That was something that I was interested in, basically. So I wanted to investigate whether experts would be subject to attributional manipulations in terms of their ratings of dangerousness of offenders than semi-experts or lay people. So I defined experts as people with, I think, above 5 years of experience, semi-experts people who are working with offenders but who perhaps are not quite at the 5 years, so they had to have some experience but less than 5 years. And lay people as well, so people with no experience whatsoever of offender assessment or working with offenders in that context. Also interested in whether the experts would be less subject to attributional manipulations in terms of their assessment of offender responsibility than semi-experts and lay people. So the same is basically what Quincy and Sir did, but adding this semi-expert group. Unfortunately, we couldn't obtain the materials, the exact materials they used, so we couldn't do an exact replication. We had to create our own vignettes, our own little scenarios. Basically, the stuff had been destroyed. You know, it was like 20 odd years old, 30 odd years old, so the stuff had been long gone by then. So that was a bit of a pity. But we replicated it as close as we could and developed our own vignettes quite rigorously, hopefully quite rigorously, we believe so. I did basically a direct comparison of expert, semi-expert and layperson judgments made in relation to internally and externally manipulated crime-based scenarios. Now, we had 18 crime-based scenarios. We had 3 murders, 3 assaults and 3 armed robberies within each internal and external condition. We kept all of our offenders male. We kept them quite generic Scottish type names like Gary and Wally, so things that are sort of Scotland-based clinicians would recognise and maybe not stereotype. So really, really basic names. We didn't mention race, anything like that. We kept all that out of it. We tried to counterbalance it to some extent. We kept ages reasonably consistent. So it was quite a long time in making these scenarios. Every participant received 9 of the scenarios. They received either an internal version of it or its counterbalanced external version. So nobody saw the same scenario that was internally or externally manipulated. So it was quite nicely randomised. It took quite a long time to work that out. We had strict group classifications, as I've already mentioned about the expertise levels. We basically had operational definitions as to what an expert was, what semi-expert was, and what a layperson was. If you're a true expert, now this is research by Mary Thompson, who's done quite a bit in the past on expertise research and who was my PhD supervisor as well. So she suggests that if you're a true expert, then you should be able to outperform non-experts on relevant tasks. So we were quite interested, are these experts really going to be able to outperform, or are they going to be similar? And that's really the crux of this and the crux of what's going on in the literature itself. We had this horrific 3x3x2 mixed groups design. If you're designing research like this, try and keep it simple, especially if you're just getting to grips with stats like I was at the time. So we had 3 crime types. We had the semi-experts, the experts, and the lay people's expertise, and we had the internal and external attribution. 55 participants in total isn't that crap sample size. We only managed to get 12 expert participants. This is not for want of trying. It was something like a 12% response rate. Most people who responded with no basically said, I really don't want to do this kind of research. I've seen so many of the judgment papers. So there was a bit of a fear about it, which was a real shame. Our semi-experts, we had MSc students. All of the MSc students also had some actual clinical experience. So they weren't just sitting at a desk reading papers. They were trainee psychologists or assistant psychologists. Quite luckily, when I was doing my PhD, is the only accredited forensic psychology master's course in Scotland, so it was really easy to get them. And 22 lay people. And they were just people that had folk off the streets, basically, who had no clinical experience, no forensic experience. I've already mentioned our methodology, basically, so I won't go into that again. The findings, so what did we actually find? So the effectiveness of the attributional manipulation, so we measured this using the causal dimension scale, just to make sure that actually they were doing what we wanted them to do. The internal ones were more internal than the external ones. And we measured these by 3x2 ANOVAs, and we found that, yeah, all the internal manipulations were rated more highly in internal causality dimensions, all the external ones were rated more highly in external dimensions, as you would expect. So that was really nice, so it worked. The actual basics worked. Key findings, this is the graph for dangerousness. We did have a number of interactions, so there was loads of main effects. I won't go into everything. What you can see from this, and this is where I'm going to maybe fall over our trip and hazard, along the bottom you probably can't see the words. This is our internal attribution condition. This is our external attribution condition. Our blue line here is our experts, our green is our semi-experts, and the pink are the lay people. So what you can see is there's a definite difference in the ratings of dangerousness across the internal and the external manipulations. Certainly, the offenders that were rated within the internal attribution condition were considered to be more dangerous. So when you place the causality on a person's, something about the person, something internal to them, on their violent behaviour, they're considered more dangerous than someone where it's placed situationally. That makes sense. That's surely just logical. What you can kind of see as well is this similarity between the experts and lay people. If you look at the slopes of the lines, they're really similar. Our semi-experts don't seem to be as affected by the internal-external manipulation. It still was significant for a main effect, but it isn't as prominent. Now, this is the next key factor that we're interested in, was this idea of responsibility. And what we find is the exact same pattern for experts and lay people, is that the individual who was describing the internal attribution manipulation is also considered more responsible for their crime than the one who basically committed the exact same crime but had maybe some external situational factors going on. Now, the manipulations, the difference between the internal and the external scenarios was literally 10 words at most. It was a few sentences, a few changes of words here and there. It wasn't like we really stressed the point in one condition and then really stressed the other point in the other. It was minor manipulations, minor changes. What I find much more interesting though is the similarity between your experts and your lay people. But in this condition, our semi-experts here, our green line, there's almost no change between, well, statistically there is no change in the assessment of responsibility attributed between the internal and the externally described offenders. And this is something that we found across all of our studies and across basically every variable, is that these semi-experts are different. So something's happening between being a lay person with no experience and being very experienced. You've got these semi-experts who are kind of out there. So what's happening in between there? So can we really say that experts and lay people are just the same? I would argue probably not, but I'm not entirely sure what's going on, even now, after years of thinking about it. So this is basically just saying what I've already said. So conclusions about the study. We've got this distinct difference in the semi-expert judgments across the internal and external categories. Why? So are semi-experts actually less biased in their judgments? So are they more balanced than experts and lay people? So are they less prone to it? Or are the judgments made by the expert group only appearing to be influenced by attributional manipulations? Are they perhaps using different risk cues from the lay people but come to the same conclusions? Or actually are the semi-experts missing the point entirely? Is something about the attributional manipulations quite important? So perhaps having an internal cause could be much more important than missing that and trying to be completely balanced. So there's quite a lot going on there, and I'll be honest, I don't really know, even though I've published this paper, I've admitted in the paper as well, I don't really know, I don't have the answers to that yet, and we do need more work on it, probably more cognitive work using maybe eye tracker or something a bit more technical, more experimental work to look into this. So moving swiftly on, study 2 was very similar actually. What I wanted to do with the second study was basically look at the judgments made using a risk assessment tool, a structured professional judgment risk assessment tool. So we looked at the HCR20. This has got 20 risk items on it, risk and protective items on it. They are, some of them are about background, some of them are about clinical risk cues, some of them are about risk management for the future, so potential risk management for the future. They're not just based on static factors, things that can't change that have happened in the past. Some of them are dynamic risk cues, so things that are changeable, so the person's living situation, for example. And the idea behind these structured professional judgment tools is that they will reduce the risk of bias, reduce the risk of sort of being swayed by funny data, and improve clinical judgment. So if they do that, then hopefully we'll see that there's less effect of this internal and external manipulation that we apply to our crime scenarios, our offender scenarios, and hopefully they should be unbiased across the two conditions. So I wanted to investigate whether the differences in attribution were apparent more or less, or indeed at all, also across there's various versions of the HCR20. So some people use it as a checklist in practice. That shouldn't be done, so they basically add up, tally up how many risk factors are present how many aren't present, and they treat it like an actuarial scale. That tends to be how we look at it in the literature as well. What should happen is that there should be a full written worksheet version. So there should actually be a written risk assessment and management plan. So we got half of our participants to do just a checklist, and the other half to do a full workup plus a check, scoring at the side as well, just to compare these out of curiosity. So there we go. I've just described all that. So that's fine. I should really look at my slides before I do talks. So the two versions, just to give you a bit more information, because I don't know if many of you will know about it. So the worksheet version is most relevant to clinical practice. It's the thing that clinicians should be using, should be doing. It guides clinicians through the relevant risk factors and protective factors. Now there's a new version out for violence. It's generalised violence, and at the end of it they should be able to produce a full written risk assessment and management plan for the individual. The checklist is shorter, so it's just basically the 20 items. It's designed initially just to be used in research. It is used in clinical practice. Sometimes it shouldn't be, but it is because it's quicker. The user basically rates all of the 20 items either as a 0, not present, so if the risk factor isn't there, then it's 0. If they think that it might be there or it's kind of there, they would rate a 1, and if the risk factor is definitely applicable to that case, they would rate 2, or they can choose to omit. And at the end, they would just add it up. There's not really any proper cut-off thresholds for what's high risk and what's low risk, but in the research and the literature, they've kind of applied those, and we applied the same ones. So it was a 2x2 design, much easier to analyse for me, that was nice. So we have our internal external attribution condition as before, and the worksheet versus the checklist version of the HCR20. In this study, we only used one crime-based vignette, and that was chosen from the previous study's stimulus material. We extended this, in the previous study there were about half a page, about a year long. This was a 2-page version, so it was much longer, much fuller, with a bit more information. To complete an HCR20 and get people to do a proper risk assessment, even that's a tiny amount of information, and that was feedback that we got. But you have to have some experimental control too. We had 40 participants. I chose to use only semi-experts in this because it was quite novel. It was quite a different approach. Nothing actually has really been done like this before, so I didn't want to not waste clinicians' time, but use valuable clinician time. So it's verging on a pilot study, to be honest, but it is a study in itself. So the semi-experts were captive, basically, at the university. They were easy to get access to, and they give us some insight. But also the semi-experts were the more interesting group based on the past study. So I wanted to look into them in a bit more detail. So we had 17 MSc students, all again with applicable practical experience too, and 23 undergraduates who hadn't taken any forensic psychology, who hadn't worked in courts and so on. So they acted as our lay people. Sorry, I'm talking nonsense. Our 23 undergraduates were fourth years who had taken a forensic psychology module. There we go. If I knew my own paper, that would help. They'd done a forensic psychology module, and I think out of the 23, it was 21 of them had worked in some kind of applied practice, either social care or healthcare, or in courts. All of the participants in the study had received some, but I will admit, limited training in the use of the HCR20. They were given the manual. There's a manual that goes with it, and I gave them a wee mini preview of it as well. But they were by no means experts in using the HCR20. However, if they were assistant or trainee psychologists in practice, it's the same level of training basically they would get unless they paid £600 for the 2-day course. But their initial training, that's what they would essentially have. So there was a significant main effect of attributional manipulation in the historical scale, the clinical scale, and the total score. So 2 out of 3 of the subscales, attribution effects were found, and the total scoring of the HCR20 attribution effects were found. Again, exact same as the previous study, what we found was that the scoring of these scales at the total score was higher within the internal manipulations than in the external ones. So basically risk was rated as higher within the internal manipulations than in the external manipulations. So if you're placing internal causality on an offender, you're going to rate the risk as high. If you're placing an external cause on their behaviour, you're going to rate the risk as lower. This has quite serious implications actually for their future treatment. And although it's I won't call one word trivial, but it's a small study, it's a wee toty study in the whole scale of things, but it's quite alarming. What's interesting, I'm going to look at my next slide. Yeah. What's interesting now is that why are we seeing these attribution effects with this group of semi-experts now that they're using the HCR20, but not in the earlier study? So when I saw the results, basically my reaction was, for fuck's sake, why can you not be simple? Because it would be much easier if you just didn't have, if you flatlined like you did in the previous study and didn't have any attribution effects going on. So this forced me basically to look into the expertise literature in a lot more detail, and it actually answered a lot of the questions raised by the previous findings and a lot of the stuff raised in past research that looked at experts and lay people alone. A key name in this field is Celia Witteman. In the Netherlands, her team do fantastic work. They were doing very similar research actually in psychodiagnostics and finding really similar findings with these semi-expert groups to what I was finding. And it's fascinating that across these similar contexts that the same stuff's happening. So the thought is that if you're just working on intuition, then basically you're going to use your gut feel and therefore be more prone to biases. And that tends to be used more so by lay people and more so by experts. So lay people use heuristics, cognitive rules of thumb, to come to their decisions in this kind of context. Experts will use their intuition, their learned intuition, rather than just gut feel. It's their learned intuition, their expertise over the years. And that's perhaps why these two groups are mimicking. Deliberation, on the other hand, a semi-expert group go through a different process of expertise development, and basically it breaks down in the middle. There's beautiful work by Dreyfus and Dreyfus, I think it's 1986, if anybody's interested I can send a paper. And it's not in psychology context actually, it's in artificial intelligence context, that looks at 5 stages of expertise development. And they suggest that actually when it comes to semi-expert judgment or novice judgment, so that middle stage, that actually their decision making, their judgments aren't quite as good, and they use more deliberative judgment naturally. So they'll use all the guidance they can get. They'll eat up all the guidance and stick to the rule books. I'm sure we've all been there when we're making lesson plans when you're just starting your first lectureship. You stick to the rules and make a nice lesson plan. Then a few years down the line, it's like you walk into the lecture and go, "Hello, I'm going to talk to you about this today," and it's not quite as structured as it could be. Any context, I suppose, is the same. So while we're in that training phase, that learning phase, you actually don't use the intuition, you use the deliberation. Now, how does that apply to this study? The HCR20 forces the people to use their deliberation. It's deliberative thinking, because they're forced to go through a structured process. And my thoughts were that actually if they're forced to go through the deliberative process, it supports their natural way of decision making, these semi-experts' natural way of decision making. And perhaps this is why we're seeing the attribution effects now. Whereas if they're just asked to make an intuitive judgment, a quick judgment, that's not a natural way for them. So it doesn't quite work out. I can see you all screwing up your faces. This is exactly how, all these expressions are exactly how I looked when I was first getting my head around this. Clearly I don't explain it very well yet. I write it better than I speak it, so read my papers. But basically it's due to the way that the expertise is developed. So rather than easily being able to say, yeah, look how different semi-experts are, and look, they're not biased at all, and now I can go on to develop training sessions and rake in lots of money when I'm older. No, it's not that simple. There's actually something else happening. So this semi-expert group are so fascinating, and actually what they're potentially telling us about lay people and experts, and the fact that they might not actually be the same as so much of the literature has told us in bias risk assessment literature anyway. I think it's really positive. I think there must be something else going on there, and that's certainly where my future direction of my work is hopefully going to go, is to find out what that little in-between stage is doing. So, conclusions about this. Attributional manipulations still affect judgments, even when the judgments are aided by a structured guideline. Judgments made using the checklist and the worklist version of the HCR20 didn't differ, which is nice. This means that the research that's done using the HCR20 is actually applicable to practice, and that the people who are using the HCR20 in practice as a checklist maybe wouldn't be doing very much different in terms of basic judgment to those who use it as the full worksheet version, although they should still do the worksheet version. So, how am I doing on time? 2 minutes. Okay, I can maybe fly through this. So, study 3, this was a final study, you'll be glad to know. Study 3, I wanted to have a wee bit more of a think about it. So, because there was so much oddness going on in the previous results, I took some time out and thought, well, actually, what's the practical application here? What's the end result of a risk assessment? And obviously, you've got to consider the context, the offender, the clinician, but one of the outputs is the risk communication. So it's not just all about the judgment. It's, we've got clinical judgment unaided, which is obviously used. We've got clinical assessments developed using the HCR20 and professional tools, but that's still judgment. What about when they communicate risk? Does the communication of risk, would that also be affected by attribution effects? So I wanted to investigate the impact of attributional manipulations on very brief, not by my choice, by the participant's choice, written violence risk communications. I wanted to analyse the quantitative variation between original scenarios, the scenarios that I've used in the previous studies, and the communications that were produced based on these. And again, looking at internal and external differences, of course. And what I then did, so I've always been very quantitative, what I then did was think, I'm really going to actually have to look into this in a bit more depth. So I did a very, very basic, at the time, thematic analysis on risk communication, on the risk communications that were produced, to try and see what kind of stuff are they saying, what are they telling us. And there's very little in the way of qualitative research in violence risk assessment in the field. Certainly I've tried to publish it and I've been told, yeah, it's really interesting, good findings, it's qualitative, we don't want it by journals. I've tried, that's 3 journals now, I've got my last not back 2 days ago. And it's a pity because you can get so much richness out of qualitative work. And it certainly opened up my eyes. Anyway, so the key quantitative findings, we did a 2x2 between groups and of us. So we had the independent variables for the internal and external attribution manipulations, and also the original vignette, so those internal and external vignettes, compared to the risk communications that we'd ask clinicians to write based on those, as if they were communicating to a colleague, basically. What we found was basically the risk communications. When we got a bunch of lay people, we had 350 participants in this study, rating the original scenarios and the risk communications. They were found to be unaffected by the attribution manipulations. So it's the first study where actually the internal and external manipulations didn't seem to have any effect whatsoever. So my face again, when I found this, thinking this will be nice and clear cut. Coming into my final year, it'll be, the attribution effects will be present and I've got all my ideas for writing. And then, of course, no, it couldn't be that simple. So I was excited because it's an interesting finding. I was also somewhat disappointed because it meant more thinking, more reading, but that's how a PhD should be. The qualitative stuff, so this is when I decided, right, let's actually look at these risk communications and see what they've said. So it was a very, very basic thematic analysis. It was my first step into the literature of qualitative work. I've done a lot more since then, but looking back at it, it was a bit basic. I've reanalyzed the data since, but again, I'm going to find the same themes, but just in a bit more depth, a bit more refined. So the themes that I found was basically repetition of factual information. Now this is based on the type of task. Obviously the clinicians should be telling us what the case is about, what the offender did, who the offender is. So that obviously it's quite practical. There was also assumptions and suggestions, so the clinicians would make assumptions based on what they'd read. Again, that's part of their job, is to formulate, to assess and to manage. They should be doing that kind of thing, you would imagine, and they should be making suggestions for future plans and future interventions, for example. False assumptions was incredibly interesting and alarming. Now, the vignette they got was about 1 page and 3/4 long. It really wasn't a long thing. Quite tightly controlled in terms of content. It wasn't hugely detailed. And yet they had these false assumptions. So 4 of my clinicians told me, and it was only out of a sample of 10, but 4 out of 10 told me that, oh, the offender has an alcohol problem or has drug problems. I didn't mention alcohol and drugs at all. I had to go back and read my vignettes to make sure that I hadn't said that. And then they based the rest of their communication was largely based on that. Now that's really alarming that they can't read 1 page and 3/4 without saying, oh yeah, the drug problem, the alcohol problem. There were various other false assumptions, like they've got a previous offending history. No, they didn't. I didn't say that. Actually, I explicitly said they didn't have a previous offending history, so that was worrying. And you can only assume if they're doing that for a research context, where they know that they're going to be assessed qualitatively and quantitatively because they were told how it was going to be used. You can only assume that it's probably happened in clinical practice as well. And everybody makes mistakes, sure. But that was one that really was surprising to me as a sort of novice researcher and everything through rose-tinted glasses. They also, because of the brevity of the article, they sought information and clarification. They wanted to know more. That's good. They should want to know more. And they suggested some future risk management suggestions too, which again is good. It's good practice. So overall, like, nothing really surprising. Themes really descriptive due to the task nature. Some of the sub-themes were quite interesting. So what I found when I looked at the risk communications that were produced based on the internal and the external vignettes, they didn't actually differ in terms of the amount of internal and external causality applied. So again, this deliberative task that the experts are taking part in isn't causing them to have their biased judgments that we saw in the previous studies on this exact same vignette. It's just not coming through in these communications. So that's quite an odd one to me. Although there were internal factors raised and there were external factors raised, but these were pretty much ballpark across all of the communications. There was no difference, well, no qualitative difference across the 10 scenarios. Obviously, it's a tiny, sorry, I don't know if totally is a Scottish word. It's a tiny wee sample, but for qualitative, it should be small. I think that the qualitative findings are the most interesting part. That's something that I do want to follow up on. I'm hopefully going to be collecting some data in the summer, extending the study and refining it, making it just that wee bit more rigorous. And I think that they're quite fascinating. Again, they throw up this contradictory finding compared to all the past research that's been going on. So what's going on there? Did I just have 10 weirdos compared to the rest of all the clinicians on the planet? Or is this representative? So as a quantitative person, I want more data. Any qualitative people in the room are probably thinking, no, just do it in more detail. So one could possibly hypothesize based on this that data extracts that are emerging from the internally based communications would populate more effective and internal factors more frequently than those from the external ones, and vice versa. Didn't happen. So I really want to explore that in more detail. Basically, I've got life's work ahead of me if I manage to do all this. And I've already mentioned that wee point. Based on this sort of qualitative and quantitative assessment of the risk communications, it can probably be quite easily concluded that the risk communications that I produced for my study, at least, or that my participants produced for me, were not prone to these attributional manipulations in the same way that judgments were, which is, I find, interesting and unusual. So why? So logically, if your judgment is biased, so should your communication be, you would imagine. But it wasn't the case. And again, if we tie back into the expertise development literature, this outlines that task time taken and the level of deliberation can affect judgment. So your initial judgment might be, yep, nutter, put them in jail, high risk. Then actually, when you take more time to think about it, more time to look at the facts of the case, the details of the case, this can then neutralise that. And that seems to be what I've found, which is quite heartening. So although the first two studies were quite alarming, this one, other than the false assumptions theme, it suggests that actually clinicians might not be quite as bad as we think. Yeah, so I just mentioned that. So hopefully this study, if it's ever published, if anybody ever wants it, it will hopefully bring forward the point that actually clinician judgment might not be quite as bad as it seems if we think of it in a bigger context, if we think of it in terms of risk communication and what they do with that judgment. So what do I want to do? So if there's any risk of bias in the judgment process, I believe this should be addressed, and potentially do this through debiasing training processes. But first of all, we need to actually know, are attribution effects important? So that stuff that it talks about in relation to study one, are those attribution effects that the experts and the lay people are picking up on, are they important for the actual assessment, or are they not? So more research on attribution effects need to be done before we can start going gung-ho and suggest that all clinicians need trained, as my 2010 paper, one of my first papers, suggests, so apologies for that. Structured professional judgments don't seem to reduce cognitive load in relation to this task anyway. They don't seem to reduce the likelihood of reliance on cognitive shortcuts such as attribution. So they're still prone to the same bias and errors as clinical judgments, which is interesting. And people who are critical of structured professional judgment tools might quite like that actually, and use that as a suggestion that we should use actuarial tools. I personally don't feel that way, but others do. So a few of the recent editorials, these are lit reviews and editorials that I mentioned way back at the beginning of the talk, have proposed that simply knowing about biases such as attribution effects, attribution biases, could reduce them. Well, actually, no. We know that they're evolved processes, they're evolved cognitive processes, they're there for a reason. They help us tackle these huge amounts of information, and the knowledge of them might help us in the short term, but actually we will always go back to using them. That's just human nature, that's just what we do. So there's a possibility of developing de-biasing training if it's suitable and if it's effective. And how would you maintain that? Should we maintain it? There has been some evidence from the counselling domain by Chen and Froel, I think that was 1997-ish paper, that actually you can reduce causal attributions within counselling to sort of reduce bias in judgments. So there is some success for these, at least in the short term. They did a follow-up, I believe, don't quote me on that, but I think after their sort of 3 or 6 month follow-up, they found that the attribution effects were still reduced, the causality was still reduced. So I think that's quite positive, but we shouldn't go too gung-ho. We should do a bit more research first. So I'm interested in the future. Are semi-experts really better at making decisions, or actually are they worse? Are they missing important causal information? Are lay people and experts actually working to the same cognitive processes with the same risk cues? They're using the same risk information. And are semi-experts using different information? So the nitty-gritty needs to be eased out. I've looked at it really broadly. It would be nice to look at it in more detail. In many, many moons to come, if I ever get round to it, and if the data suggests it's the correct thing to do, possibly developing training for clinicians to tackle attribution effects in their judgments. But again, this would completely depend on what the data tells us in future studies. So thank you for listening to me. I know you all had a long meeting before coming here, so thank you for coming as well. I think I would have just went home. So it's very nice to see so many people. If anybody's interested, obviously you can just talk to me just now. My email address is jai.honey2@napier.ac.uk, and I also have a work Twitter, but actually I just talk about cakes most of the time, have a bit of a rant about public transport. So if you're interested in public transport cakes and a little bit of research, then feel free to add me on Twitter. But thank you so much. Any questions?